Cultural competence is the clinical ability to provide effective services across demographic differences. It has a direct impact on whether a patient's treatment actually works. A client's culture dictates the basic terms of engagement. It determines how they understand their own substance use, and it governs whether, when, and how they decide to seek professional help. Culture also shapes the presentation of symptoms. It influences how a person expresses physical and emotional distress, and it sets their baseline expectations for what a counseling relationship should look like. When a clinician ignores these factors, they risk misreading the client entirely. This leads to ruptured therapeutic alliances and the delivery of mismatched interventions that fail in practice, no matter how technically sound they appear on paper. Navigating these dynamics requires a rigorous clinical skill set. It is an applied science of human behavior, not a matter of political correctness. Because cultural factors dictate patient behavior at every level, this competence cannot be treated as an add-on. It must be woven into the fabric of every screening, assessment, treatment plan, and referral to ensure clinical efficacy. The field has historically treated cultural competence as a fixed achievement, a finite checklist of traits to memorize and check off. Contemporary practice replaces that static model with the concept of cultural humility. This reframes the work as an ongoing, lifelong process of growth, self-reflection, and adaptation. Cultural humility operates on two core tenets. The clinician must treat the client as the ultimate expert on their own life, and the clinician must actively recognize the inherent power imbalances present in the helping relationship. The required clinical stance is one of openness. You approach each client with deep curiosity, intentionally setting aside assumptions and abandoning the illusion of mastery over someone else's experience. This remains true even when the clinician and the client share a demographic background. Shared group membership does not guarantee a shared life experience. Adopting this stance acts as a primary safeguard against two distinct clinical errors: cultural blindness, which is the false claim of treating everyone exactly the same, and stereotyping, which reduces individuals to interchangeable members of a group. This diagram illustrates SAMHSA's structural framework for cultural competence. To be effective, the clinician must develop three interlocking elements. The first block is cultural awareness. This requires clinicians to turn the lens inward, conducting an honest self-assessment of their own attitudes, beliefs, and assumptions. Every counselor operates through a cultural lens. Unexamined bias, particularly implicit bias that exists outside conscious awareness, acts as a distortion field that degrades patient care. Recognizing it is the indispensable starting point. The second block is cultural knowledge. This involves learning the specific histories, values, communication styles, and systemic barriers of the populations you serve, without reducing them to caricatures. This demographic knowledge is a tool to inform your clinical approach, but it never replaces a highly individualized assessment of the person sitting across from you. The final block is cultural skill. This is the mechanical ability to translate your awareness and knowledge into adaptable clinical practice, modifying interventions to fit the client's context, and communicating effectively across differences. These three elements, awareness, knowledge, and skill, must operate simultaneously. Without this triad, the counselor risks delivering interventions that do not fit the client's reality, which undermines the therapeutic alliance. Clinical culture extends far beyond the traditional boundaries of race or ethnicity. A patient's identity and care needs are shaped by cross-cutting factors, including age, gender, socioeconomic status, geography, and trauma. To understand how these variables interact, clinicians rely on the concept of intersectionality. Consider an older, rural immigrant woman and a young, urban, second-generation man. They may nominally share the same ethnicity, but their intersecting realities produce vastly different clinical needs. A person is never strictly their gender or strictly their income bracket. The combination of these variables produces a completely unique configuration. The clinician's role is to hold all these intersecting factors in mind simultaneously. The specific architecture of a client's life must be thoroughly investigated, never assumed. For many populations, current substance use is heavily influenced by historical and intergenerational trauma. This is the cumulative emotional and psychological wounding of a group across generations. This trauma stems from specific historical events, including colonization, slavery, forced removal, genocide, and long-standing systemic discrimination. Clinically, this collective wounding frequently manifests as a profound protective mistrust of institutions, heavily impacting how a client views the treatment system itself. This history alters the psychological meaning attached to substance use, and it dictates the conditions under which a person will feel safe enough to ask for help. Recognizing this legacy means accepting that clinical trust cannot be demanded, it must be earned over time. Effective healing often requires the clinician to engage the client's cultural identity and broader community, rather than treating them in isolation. Applied demographic strategies are equally critical when addressing gender. Women and men present differently in clinical settings and require distinct, gender-responsive approaches. Women's treatment frequently revolves around addressing histories of victimization, managing pregnancy and caregiving responsibilities, and navigating the heightened societal stigma directed at women who use substances. Because safety is the prerequisite for recovery, comprehensive case management, integrated trauma care, and child-related services are often essential components of a woman's treatment plan. Men's treatment requires a different focus. Clinicians must address deep socialization patterns surrounding stoicism, self-reliance, and emotional suppression, all of which hinder engagement. These patterns create clinical blind spots. Men frequently underreport depression, express their distress through irritability or risk-taking, and carry a high, often undetected, suicide risk. Gender-responsive care also demands thoughtful, highly individualized approaches for transgender and non-binary clients, ensuring their specific physical and psychological safety needs are met. The utility of gender-responsive care lies in its ability to anticipate frequent behavioral patterns and needs, giving the clinician a baseline strategy without defaulting to rigid assumptions about the individual. Effective practice must adapt to the values of specific communities. This might mean honoring tribal sovereignty and traditional healers for Indigenous clients, or recognizing the central role of faith and extended family in African American and Latino communities. When treating Asian American and Pacific Islander clients, clinicians must frequently navigate complex dynamics regarding family honor and intense stigma surrounding mental health. This diagram illustrates minority stress, a framework vital for treating LGBTQ+ clients. It maps the physiological and psychological impact of chronic strain. Discrimination, family rejection, and internalized stigma act as continuous pressure points that elevate the risk for substance use and co-occurring disorders. Mitigating minority stress requires proactive clinical effort. Securing engagement means intentionally creating a safe, affirming environment, which includes using correct pronouns and stripping assessments of heteronormative assumptions. Culturally responsive care is incomplete without ensuring access for people with physical, cognitive, or developmental disabilities. These clients face tangible barriers to entry. They navigate inaccessible facilities, severe communication obstacles, and a persistent lack of specific staff training. Clinicians must actively challenge and dismantle the harmful, mistaken assumption that individuals with disabilities are somehow less capable of, or less suited to, rigorous treatment. Linguistic access is equally vital. When a client speaks a different preferred language, clinicians must use qualified, trained interpreters. Relying on family members, especially children, is a clinical hazard. Interpreters mitigate the clinical danger of direct translation errors, ensuring that specialized medical and psychological terminology retains its precise meaning across language barriers. Providing these accommodations, along with translated materials at the appropriate literacy level, is a clinical necessity. It is also an unyielding ethical and legal obligation. Outside of clinical modalities, many clients rely on spiritual beliefs, religious frameworks, or traditional community healing practices as their primary mechanisms for resilience. A responsive clinician explicitly asks about these resources and incorporates them into the treatment plan, provided the client wishes to use them, avoiding any temptation to impose their own beliefs or dismiss the client's. Inside the counseling room, cultural humility translates into concrete behaviors, consistently asking rather than assuming, and deliberately adopting the client's preferred terminology to frame clinical issues. It requires an acute awareness of nonverbal cues, the meaning behind eye contact, physical touch, personal space, and the use of silence varies wildly across cultures. The clinician must remain constantly curious about what a specific behavior means to the person in front of them, rather than instinctively filtering it through their own cultural norms. Because cultural competence is an ongoing process, A clinician's skill degrades without the active use of specific tools to sustain their growth. Self-assessment instruments are utilized regularly to track a clinician's baseline awareness, measure their evolving knowledge, and surface hidden blind spots. Clinical supervision functions as the primary safety net. It provides a structured, secure environment to process difficult cross-cultural encounters and carefully examine personal bias. Sustaining this growth requires deliberately eliciting feedback from clients and colleagues and viewing clinical missteps as essential learning opportunities rather than threats to professional ego. The ultimate goal of cultural humility is not clinical perfection. It is the commitment to ongoing, honest growth that respects and honors the profound complexity of the patient.